This week, I'm speaking with Dr. Rajiv Shah. He is president of the Rockefeller Foundation. He previously served in the Obama administration as the USAID administrator, and he worked very much on the U.S. response to the Ebola epidemic. Now that he's at the Rockefeller Foundation, he is part of an ambitious plan they have launched to ramp up COVID-19 testing nationwide over just a matter of weeks. The foundation has a history of working on outbreaks of disease in this country dating all the way back to the 1918 flu pandemic. Take a look at this.
You have to move from panic and posturing to a data-driven, evidence-based response. And that starts with access to testing and data around who has the virus and where are they. We're bringing together industry, science, and government to rapidly scale up access to testing so vulnerable families and essential workers can go back to work and be safe as they do so.
Dr. Shah, good to have you with us.
Thank you for having me, Margaret.
There is funding that Congress has put aside as part of this CARES Act to help states begin contact tracing, to do some testing. Your plan, however, calls for $100 billion to roll out a nationwide testing plan. Give us a breakdown of what you are proposing, how it's different than what's happening now.
Well, thank you, Margaret. And I do think the Rockefeller Testing Action Plan, developed with a broad range of partners, is in fact different from what's happening today. For starters, we're at about 1 million tests per week. Today, we've been stuck at that level for 3 to 4 weeks now. But we're still far, far shy of where we need to be in order to open parts of the US economy and in order to protect those really brave, courageous, essential workers that are out there keeping the rest of us safe. And so the Rockefeller Foundation pulled together experts from science and industry, from Republican and Democratic prior administrations, and identified an action plan that could get us from 1 million tests a week now to 3 million tests per week within about 8 weeks, and then to 30 million tests per week within about 6 months. But the reason we need that higher level of testing is without testing, you really don't have data on who's positive. And when you don't have data, you can't drive a data-driven pandemic response, and you end up either reopening everything or shutting everything down. One strategy puts millions of lives at risk. Another strategy causes tens of millions of American households to be economically choosing between their own lives and their livelihoods and their ability to feed their children. So neither outcome works for us as a country. And that's why the Rockefeller Foundation put out this ambitious plan and has invested almost $50 million to help accelerate the coronavirus response here in the United States.
So when you say testing, what are you talking about? Is it testing to see if somebody had antibodies, as in they had the virus in the past? Is it a test before someone walks in the front door at their employer? How often do you have to test someone?
Well, in the first instance, you're actually talking about the diagnostic test. So not the serum antibody test that would tell you if you have had exposure in the past, but rather the actual diagnostic test that tells you, do you have coronavirus or not, COVID-19 specifically. And the reality is countries that are succeeding at responding to this effectively, Australia, New Zealand, South Korea, Taiwan, they are conducting a much higher level of diagnostic testing. For every positive case, they're testing somewhere between 60 and 75 cases, most of which are negative, and then there's one positive. In the United States, it's 1 in 5. And for every 5 tests we're doing, we're finding one positive, which is really a signal that we're not doing anywhere near enough testing relative to those countries that are more successful at containing coronavirus. Now, there will likely be a role for the type of test you mentioned, the serum antibody test, to identify whether someone has had COVID-19 or at least has some presumed immunity. But we think it's still months away from having the data on knowing whether the titers, the levels of antibody presence matter and how much they do matter, and B, whether the tests are good enough and precise enough to have a high number of, to have a very specific and sensitive test that gives you confidence in the test result. But before we even get to that, we have to fix diagnostic testing in America. Otherwise, we're stuck between either total lockdown or complete risk-taking, neither of which will work for Americans.
So what kind of test do you envision? Is this something that someone at home can do to themselves, or do they need to go get a blood test, or those swabs that we've seen put up the back into your throat?
So we were very specific about this. We said to get from 1 million to 3 million tests per week, we can do that with the technology we have today. We can do that with the swabs that you mentioned, the nasopharyngeal swabs. There are some new tests that are using saliva-only swabs, which are, of course, safer and easier to collect, and therefore you can let many more people go through the process of that collection. But to do that, we need to unlock the 2/3 of Americans' molecular testing capacity that exists in university labs, in research labs, in small labs around the country that are currently not being utilized to their full extent. And so we proposed very specific actions, for example, setting a common reimbursement rate for tests, whether they are done at a lab that's considered in-network or out-of-network. Like right now is not the time for insurance industry prior arrangements to define whether Americans can have access to a test. We have proposed that every state create an emergency operations center to track on a day-to-day basis the excess capacity for molecular testing that exists in their labs and direct people making requisitions to those labs. Often, you just need the data and visibility and IT connectivity to those labs so that they can be part of the solution as opposed to just being underutilized when we desperately need them. And we've proposed putting boots on the ground and specifically launching a community health corps that would have between 100,000 and 300,000 people, initially to both expand collection of specimen, in this case through the swabs, but also to do the contact tracing so that when test results come back, someone can interview someone who's been positive, identify who they then need to talk to. By the way, these are all tools and tips that we deployed as Americans quite effectively in West Africa in the September, October, November timeframe of 2014. And we beat Ebola in a very resource poor setting. We can beat coronavirus here, but we have to start being more focused and data driven and evidence based in our response.
And I love that idea. You've talked about it being kind of like a Peace Corps or America program to get people out there to track down who's been exposed through contact tracing. Now, there's money already in this bill Congress wrote into law that has the CDC help with contact tracing, but it seems like it's up to each governor to start their own program. Is what you're proposing going into each state, or you're saying this all needs to be coordinated on a national scale?
Well, there absolutely needs to be coordination at the national scale. And whether it's coordinated by the federal government or right now the Rockefeller Foundation and its partners, including dozens of states and cities and even some Native American nations, are working together to try to bring together, share best practices, share learnings, procure supplies together so that we can access greater volumes of supply from an industry that's pretty fragmented and has not yet dramatically increased its production of these necessary test kits. But that's just a substitute for what should be strong, coordinated federal action at a time when our country really needs it.
I mean, from all the governors we've had on Face the Nation, we've talked to them, they pretty much say that they're in the lead in figuring some of this out themselves. And one of the problems with solving the testing challenge is that there are so many complications at each part of it. First, it was getting the tests. So you had governors go contact other countries and secure them. Then it was getting the lab capacity, which you talked a little bit about, that it kind of varies by each area and each state how much lab capacity they have to run the test. But then you hear from people like the governor of Illinois that it's the cotton swabs and it's the VTM, viral transport mechanism, he said, that they don't have in Illinois. So the nuts and bolts of this also seem to be kind of congested here.
As you point out, they said, well, testing capacity is a constraint. It's not. We know that America has 2/3 of its capacity is laying underutilized. And we're starting to see that come online with some efforts we're pursuing, but there's a lot of processing capacity. It needs to be brought online much faster. And there's some very simple actions that can be taken at the state level to do that. The specific roadblock you mentioned, procuring enough supplies of critically needed testing items, swabs, but also the actual lab kits and testing equipment, that's a tougher problem to solve. And that's why we're pulling together states and cities and engaging in a larger scale, longer term procurement so that industry manufacturers can scale up to meet much larger purchase orders.
Are you in touch with the White House? Have you pitched this to them?
We are coordinating our efforts with the relevant departments in the federal government, with states, and with localities. And the reality is, now's not a time for partisanship. We just want to be helpful in serving the American people. And there have been prior examples of getting this right. I mean, when we were in West Africa in 2014, we got the testing challenge down from, it was taking 8 or 9 days to get a test result for someone that was a suspected Ebola carrier. We got it to under 4 hours. And we did that by deploying Department of Defense laboratories, using World Food Program helicopters to transport blood samples, by training a small army, almost 10,000 community health workers across West Africa to do the testing and contact tracing work. We as Americans know how to lead this kind of a response, and we're working with everyone who's willing to work with us to make it more effective here in the United States.
Our country knows how to do this overseas. The challenge is trying to do it at home. Do you think that it's a mistake that there is no USAID presence, no administrator sitting as an advisor on the current task force?
Well, every administration chooses to organize themselves in different ways, and in an effort to just work with everybody, I don't comment too much on any one organization. I do think it's important that America lead this effort at home and also look out to prevent this crisis from having rebound waves of the epidemic coming back to our shores from other places. And in that context, there's a need, in my view, for USAID, which is our international development agency, to be well resourced in tackling and supporting other countries in tackling this challenge effectively, even as we scale up the effort here at home. And it's just one of those obvious points, I suppose. But any country that continues to serve as a significant reservoir of COVID-19 is going to present a threat to the rest of the world, no matter how much we try to seal ourselves off. This is a very transmissible virus. It's going to remain that way. It's likely to be a problem for 12 to 18 months before there's broad access to a vaccine. And in that period of time, America should be persistent here at home and a real leader abroad.
Dr. Rajiv Shah of the Rockefeller Foundation, thanks so much for sharing your ideas.
Thank you, Margaret.